Good afternoon, everyone, and thank you for joining this week's NDARC webinar. My name is Olivia Price. I'm a PhD student here at NDARC, and it's my pleasure to be chairing today's webinar. Before we begin, I'd like to acknowledge that I am joining from the unceded territory of the Bidjigal people, who are the traditional owners of the land. This always was, always will be Aboriginal land. We're lucky to have Professor Bayard Roberts from the London School of Hygiene and Tropical Medicine giving today's webinar. Bayard is a mixed methods public health researcher who focuses on mental health and non-communicable diseases among populations affected by armed conflict. Today, he will be discussing the neglected challenge of harmful alcohol use among forcibly displaced populations and will offer some policy and research recommendations. After Bayard's presentation, we will be joined by Professor Nadine Ezard for a question and answer session. Nadine is an addiction medicine clinician researcher with over 30 years experience in addiction medicine and public health practice in Australia and international contexts. She is the inaugural director of NCRED, the National Centre for Clinical Research on Emerging Drugs, and has a particular interest in substance use disorders among refugees and other displaced populations. You can log questions for Bayard and Nadine using the Q&A button at any time throughout the presentation. If you're like me and get nervous asking questions in these kinds of settings, please don't be. This is a great opportunity to ask two experts all your questions, and you can always hide behind the anonymous tick box. We might not have time to get to all your questions, but we will do our best. But that is enough from me. So Bayard, I'll hand over to you to get the presentation started. Thank you.
Thank you very much, Olivia, and very grateful for the opportunity to present today to NDARC. So really appreciate this opportunity. In particular, thanks to Olivia, Laura, and Nadine for this. So I provided here an outline of what I would like to cover over the next 30 minutes or so. And I'm firstly going to give a very brief overview around forcibly displaced populations, and then discuss some of the risks of harmful alcohol use within forcibly displaced populations, and then look at some of the responses to addressing harmful alcohol use, although there are not many. And because of that, I'm going to focus on an example of an ongoing intervention study that I'm involved with, which is called Change. It is ongoing, so we don't have results for that yet, I'm afraid. And then I'll finish up with a few conclusions and key messages. And the focus of the presentation today is very much on low and middle income country settings. That's partly because that's where my work has been, but also where the vast majority of forcibly displaced populations live. So moving on to forcibly displaced populations here. The slide here is from the United Nations High Commissioner for Refugees, and it shows this long-term trend of increasing numbers of forcibly displaced populations. In other words, people that have been forced to leave their homes because of violence, of threats of violence, persecution, and insecurity. And this graph starts at 2014, but we really see a period of at least 10 years before that where we see increasing numbers. So we're in a situation today where we've got a record number of forcibly displaced populations, well over 120 million people now. And what we also see is the majority of those are what are called internally displaced persons, or IDPs. So these are people that have been forced to flee their homes but have remained within the border of their country. This is in contrast to refugees, for people being forced to flee their homes but have crossed an international border, typically to the neighbouring country. The implications of this distinction between an external migration and forced displacement is that refugees are typically afforded a greater degree of protection under international refugee law, particularly support from the United Nations High Commissioner, UNHCR, and other agencies. And so as typically they would have better health outcomes than in contrast to IDPs who remain within their own country. And so when we think of key health outcomes of concern, such as mortality, sexual and reproductive health, mental health, burden of infectious disease, these are typically higher amongst IDPs compared to refugees. Other key features to bear in mind when we think about forced displacement is that around 90% are in low and middle income countries, and that's really where the vast majority of needs are and resources should be focused. We also need to recognize that there are repeated cycles of displacement. Many people that have been displaced are displaced more than once. If we think about situations currently in Gaza, where we have people that are displaced constantly within the borders of Gaza as IDPs, we're also seeing in Eastern Democratic Republic of Congo, the moment people being displaced from the violence there that have been displaced repeatedly, often as both refugees and internally displaced persons. Another really important feature to recognize, and this has implications when we think about alcohol and substance use needs and responses, is that the displacement is typically over a decade long, rather than short-term acute displacement. And this has implications for healthcare responses. If people are displaced for years and typically decades, the healthcare needs and responses really need to be focused on a model of sort of chronic care needs, primary care, rather than acute emergency vertical responses to address, for example, infectious disease outbreaks or malnutrition. The challenge in many situations is that the humanitarian response model is really predicated on that acute emergency phase and is less well adapted to address the longer term health needs that are in effect characteristic of contemporary forced displacement. So moving on to the risks of harmful alcohol use amongst forcibly displaced persons, there are a number of key and pretty obvious predictable risk factors. So high exposure to traumatic events. There have been hundreds and hundreds of surveys that have been done that show very high levels of exposure to violent and traumatic events linked to exposure to the warfare and the fighting and the forced displacement itself, and violence, including sexual and gender-based violence, experienced by civilian populations. This also inevitably leads to a high burden of mental disorders amongst a proportion, not all, but a proportion of that population. And we see in the graphs here how on the left-hand side, we see depression amongst conflict-affected populations is significantly higher than in the global population, according to the Global Burden of Disease database. And we see a similar picture on the right-hand side with anxiety and also post-traumatic stress disorder. So we have this key risk factor of high exposure to traumatic events, which is a risk factor for harmful alcohol use, but also a very strong risk factor for burden of mental disorders such as post-traumatic stress disorder, anxiety, depression. We also have a number of characteristics related to forced displacement if people are moving into these long-term displacement settings, which are typically characterized by often high levels of unemployment, high levels of poverty, boredom that comes with that, loss of support, loss of assets, roles, and in many cases, hope and meaning. And these factors have been strongly associated not only with a range of mental disorders, such as those shown here, but also with alcohol use disorder. And this association is particularly characteristic among men. What is also important to bear in mind when we're thinking about, in this case shown here, the burden of mental disorders, is a huge treatment gap globally for treatment for mental disorders. And this equally applies for substance use needs. The challenge being that in crisis-affected, forcibly displaced populations, we really have no idea what actually that treatment gap is. So I've given to some examples that were provided to us as part of a research study that I'll come on to in a moment in Uganda. So these are with South Sudanese refugees in Uganda. And they highlight some of the reasons people, and men in this case, turn to high levels of drinking, which is really seen as a way of forgetting, of addressing pain, the sense of loss of war and meaning. And a way of trying to deal with the stress that comes with the experience of war and forced displacement. I've highlighted at the bottom here a number of impacts from harmful alcohol use. I'm sure they will all be extremely familiar to you all. So we clearly have this comorbidity and association with poorer mental health, but also physical health impacts. And it's worth highlighting here that in the case of forcibly displaced populations, we're seeing increasingly high levels of burden of non-communicable diseases. that's posing a real challenge to humanitarian agencies and government agencies in meeting those NCD needs amongst crisis-affected populations. And clearly, harmful alcohol use is a contributing factor to a number of NCDs. It also can impact on health-seeking behaviour and also the ability of people to self-manage health conditions, particularly chronic conditions. There's clearly a number also of social and economic impacts at individual, family and community level, an ability to earn and maintain income. And finally, but by no means least in this context, is it being a factor on the pathway with gender-based violence, which is a real concern in many crisis-affected settings, including forcibly displaced populations. So moving on to thinking about the responses and, in effect, gaps in responses for harmful alcohol use amongst forcibly displaced populations. Some major gaps are the fact that at the moment, there is very limited inclusion in humanitarian guidelines. So the major guidelines are things like the SPHERE standards and IAC guidelines on mental health and psychosocial support, MHPSS, in humanitarian settings. It does recognize substance use, including harmful alcohol use, but there's very limited detail in there. The good news is, and we'll maybe come back to this later, is there's been some ongoing development led by WHO and UNODC on trying to develop guidance on this. Without any guidance, it's in effect makes it that bit harder for agencies to be willing or able to respond to the issue of harmful alcohol use and substance use more broadly. Importantly, there's a lack of evidence-based, scalable, effective interventions. There's a review done by Jeremy Kane and Green and Co. On this, and I think around 5 or 6 interventions were identified for substance use broadly, not just harmful alcohol use, amongst crisis-affected populations. So we've really got a very limited number of interventions that have been specifically developed for these populations and meaningfully evaluated. And there is therefore there is a need, and this has been identified by a sort of large-scale expert consultation, for a need for contextually relevant and community-based interventions to respond to the challenge of harmful substance use broadly and harmful alcohol use specifically amongst conflict or crisis-affected populations, including forcibly displaced populations. So what may explain some of these gaps? First and foremost, there's a really limited evidence base on harmful alcohol use. So you simply don't really have a proper understanding of the patterns of and the prevalence of harmful alcohol use amongst forcibly displaced populations, let alone service utilization patterns, clinical needs in service settings, or indeed the effectiveness of interventions. There are clearly many competing health needs and very limited resources and capacity in humanitarian settings. High levels of stigma around alcohol use in these settings, as we see globally, but it equally applies in these settings. Certainly work that I was involved with in northern Uganda, where there was an amazing willingness of people to talk about their health needs, including mental health needs and the impact that the conflict was having on their mental health needs, much less willingness to talk about harmful alcohol use. There's a wide acceptance of a problem, but much less willingness of people to talk personally about that need. So stigma is extremely high. And a number of perhaps more speculative reasons are that perhaps it's considered outside the remit of humanitarian response. We still have this model that's very perhaps still predicated on these short-term responses, very much around controlling infectious disease outbreaks and malnutrition. And these longer-term health needs may be considered beyond what's possible or appropriate in humanitarian responses. Maybe it's also considered too paternalistic, that humanitarian agencies don't want to get involved in these longer-term sort of behavioural change interventions. More speculatively and perhaps controversially, some work we did a few years ago trying to unpick this question of why isn't there more being done on harmful alcohol use. Quite a lot of the responses, this was amongst sort of key experts, was a sense that there's quite a drinking culture amongst particularly international humanitarian workers, And as a result, there may be less willingness to engage in this topic as a whole. And so it just isn't being pushed at the sort of operational level and programming level by international aid workers, perhaps. And more broadly, we're in these contexts, national contexts of weak national alcohol policies, weak implementation of them, and in some cases, strong industry influence. There's some very interesting studies that have looked at the way in which alcohol companies have, in effect, written a number of alcohol policies in countries, including ones that have been impacted by conflict. So I'm going to spend a few minutes talking about this change intervention, because it's an example of a relatively rare example of an intervention that's being developed to address harmful alcohol use amongst conflict-affected populations. So I'm co-principal investigator of this, but really the main principal investigator is Daniela Fura at Bremen University. So it was in the context of recognizing, in two contexts, Ukraine and northern Uganda and South Sudanese refugees in northern Uganda, of quite high levels of drinking, demand amongst the communities particularly and stakeholders there to address the issue of harmful alcohol use amongst men. And so we developed this intervention. And so the aim of the change intervention, the project, is to develop and evaluate a new psychological intervention called Change to address alcohol use disorder and psychological distress among conflict-affected populations in Ukraine and Uganda. And we wanted to evaluate the effectiveness and cost-effectiveness of this intervention, and also explore implementation processes and mechanisms that may support the uptake of the change intervention. And we are partners from Health Right International University of Copenhagen in Uganda, and then National University of Kyiv, Mohyla, and Words Help in Ukraine. And it's funded by the Wellcome Trust and UK NIHR. So the overall approach that we've taken in the Change project is focusing a lot on the treatment intervention development. I'll come back to that in a moment. Conducting treatment cohort and feasibility trials, and then full RCTs on cost effectiveness, and then in-depth investigation on implementation processes using qualitative methods, and also exploring the potential for scaling up change, so the scalability of the change intervention. And so it's taking place in Uganda and Ukraine. And in Uganda, it's in Rhino and Mvepi refugee settlements in northern Uganda, and it's with South Sudanese refugee men. And we did recruitment at the household level, and it's face-to-face. In Ukraine, it's slightly different. We're focusing on men still, but the recruitment is slightly different, and it's shifted. Originally, it was intended to be face-to-face. Now it's shifted to be telephone online over Zoom because of the situation in Ukraine. When we started this project, it was before the Russian invasion of the second Russian invasion of Ukraine. So we've obviously had to adapt it quite a lot, but it's still ongoing. For the purposes of the lecture today, I'm going to really focus more on the Uganda trial because we're much further along with that. The RCT has been completed. Unfortunately, we don't have the data yet. And a couple of things to highlight. In both contexts, we're interested in focusing on, we focus on men because the reported levels of harmful alcohol use were much higher amongst men than women, and the risk factors towards alcohol use were different for men than women. And we also focus on men that have both harmful alcohol use or alcohol use disorder and psychological distress, because there are high levels of comorbidity between those conditions. So just like taking a slight step back now with this, our intention was to really try and align the change intervention with ongoing work by WHO, and particularly their intervention called Problem Management Plus, or PM Plus, as it's known. The reason why we were keen to do this is that in Uganda and Ukraine, we saw these high levels of comorbidity of alcohol use disorder and psychological distress, common mental disorders. And so we identified the need for transdiagnostic intervention, which WHO's PM Plus is, and also by aligning with WHO's PM Plus, it would support scaling up, because PM Plus is being rolled out in many different settings. So there's an advantage there. So briefly on Problem Management Plus by WHO, it's a scalable transdiagnostic intervention based on psychological treatments, largely around cognitive behavior therapy. And it's intended for people impaired by distress in communities exposed to adversity. This sounds a very broad definition. In reality, it's largely been implemented and evaluated with crisis-affected populations, particularly forcibly displaced populations, and in some other settings with survivors of sexual and gender-based violence. It consists of up to 8 sessions addressing things like stress management, problem management, motivation, social support, and is delivered importantly by peers or lay workers. So these are people that don't have formal degrees or qualifications in, for example, counselling and mental health. They receive shorter term training, and they're often from those affected communities. It can be delivered in a range of formats. And it's really the intention behind WHO and the partners who help develop it is to address this global treatment gap for mental health, and particularly in crisis-affected settings. So it's because it's very feasible, it's hopefully scalable as well. So we were keen to build on PM Plus by adding in components to address harmful alcohol use. So the process for the development of the change intervention we've shown here. So on the left-hand side, and a lot of this work was led by our colleague Abhijit Nadkarni. So the process was shown on the left-hand side was identifying components of evidence-based psychological treatments for alcohol use disorder through doing a meta-review of psychological interventions for AUD. And then we selected a number of feasible and accepted components for a Delphi survey of mental health experts. And then shifting to the right-hand side, we wanted to make sure that these components were contextually appropriate for refugee camps in northern Uganda and in Ukraine. And so that was done with a range of in-depth interviews with people from those areas, examining these explanatory models for AUD in these settings. And then these were used to develop a theoretical framework through treatment development workshops with experts. And then this resulted in the change intervention. So this is what the change intervention looks like. It consists of 6 weekly sessions of approximately 90 minutes each. It's over 3 phases. Each phase is around 2 weeks each. The first phase consists of some initial work around assessment, initial feedback, understanding about the intervention, psychoeducation, and identifying high risks situations for that individual. And it is on a one-to-one basis. And then it moves on to phase 2, which is really building in some of these psychological components around skills training, social network development, drink refusal skills, handling peer pressure, relaxation training, and so on. And these incorporate and build on some of the elements from Problem Management Plus, PM Plus, and WHO. And then the third phase is relapse prevention. And this involves a range of activities shown at the bottom around goal setting, action planning, motivational interviewing, some homework and information booklet, and so on. And briefly, I suppose that a key element of PM Plus and also change is this use of peers, so non-specialists, in the hope that it makes it more feasible and scalable, and also by using people potentially from that community, it also makes it more relevant to that population. So in the case of change, the people we were using were from northern Uganda, and in some cases from the refugee camps. They may have had a university degree, but not necessarily in, for example, in counselling or mental health related qualification. They received 9 days intensive training, and then there are a range of supervisory activities to support them from specialists, but also through peer support and monthly online support and debriefing sessions. And this is our trial design, if you like. Our hypothesis was the change intervention together with enhanced usual care will be superior to enhanced usual care alone in increasing the percentage of days abstinent. In enhanced usual care, in effect, there is no provision in the context of northern Uganda for refugees for addressing harmful alcohol use. So it was an information sheet that was provided by community health workers on harmful alcohol use. and referral sources for that, and some training to those community health workers. And then we recruited 500 people in total. So these are men aged over 18 that had an audit score of 8 to 20. So really, this is only addressing mild to moderate alcohol use disorder, and that's a limitation potentially. And also a K10, so a Kessler 10 score, psychological distress of 16 and over. And so we had 250 men in each arm. And their follow-ups are at 3 months. So the primary follow-up was 3 months, but we also had follow-up at 12 months as well. And the outcomes are the percentage of days abstinent using timeline follow back as the primary outcome at 3 months. And then we have a range of secondary outcomes at 12 months, which also relate to days of abstinence, but also alcohol misuse using audit, a range of outcomes related to psychological distress, depression, anxiety, symptoms of PTSD, and then also outcomes related to economic assessment in order for us to do some analysis of the cost effectiveness of the change intervention. I mentioned earlier that we had a number of work packages. We had one on implementation where we don't have the results of that yet. The data are being analysed, but it has the advantage of being kind of very in depth and using theory to help explain some of the implementation processes. This is fairly novel. In many cases, particularly with interventions for scalable mental health, or studies and trials on scalable mental health interventions amongst conflict-affected populations, there's been a big focus on the epidemiology of the trial, much less on the implementation side. So we're still not picking up a lot of lessons for why things worked well or why they didn't. Hopefully within a change study, we'll be able to get those. We also have a work package, which I've shown here, which looked at the scalability of the change intervention. So if it's effective, what is the potential for scaling it up in these settings at a meaningful scale in order to address the treatment gap? And in the case of Uganda, we held around 30 to 40 key informant interviews in the study setting, and also at the sort of national level in Kampala. And we also held 2 theory of change workshops in Arua and Kampala. Arua is in northern Uganda, where we're near the refugee camps. And we used the CFIR implementation framework to guide our work. And what came out of this is a number of key barriers that we use to inform our theory of change workshops. So how do we identify key pathways to address these barriers, and what are the key outcomes that we want achieved if we are to scale up this work, and what are the activities or interventions that are going to be required to achieve these outcomes? So I've shown here summarized here these key barriers around the need for greater community engagement and sensitization because of low levels of awareness around harmful alcohol use, but particularly stigma around it. Importantly, the need for staff capacity and support so in these settings. And this feels like a really important topic that was raised. And it equally applies to many of these, for example, WHO's PM Plus and other scalable interventions. There's this big focus on using peer-led interventions. And in many cases, these might be community health workers or other people from the community. And while there's been this important focus on understanding whether these interventions like PM Plus are effective in a range of settings through the use of trials, there's been much less focus on the implementation side and understanding what the burden is on those people delivering the intervention and what their needs are and the supervisory and support needs that they need. And so this came up a lot in the workshops in Uganda, and then a number of sort of key outcomes that are required to support this were raised, and also a number of interventions or activities from the theory of change workshops. So these not shown here, but I think this is a really critical issue if we're thinking about scaling up these interventions. How are we going to support the lay workers that are delivering these interventions, because it hasn't been, I don't think, properly addressed, at least in research so far. And finally, at the bottom, quite a lot of focus on how we can integrate services in order for them to be meaningfully rolled out. It's not, it won't work if we just have vertical services for harmful alcohol use in these settings. There isn't the capacity, the money, and I don't think the interest to deliver them as standalone services. They need to be integrated into existing health services at the community level and potentially other humanitarian services. So, for example, or activities. So that might be around protection, for example, gender-based violence, but it may also around livelihoods. So a lot, sort of some examples given here of how we could try and achieve that if this is effective and scaled up. So a number of limitations for change include that it is focusing only on men because this was where the demand was felt needed. It does not address people with more severe AUD. The long-lasting effects of brief scalable interventions, such as Problem Management Plus, are really less clear. There's good evidence on short-term effect, mild to moderate effect, less clear on longer-term effect. And there is a risk that the briefer we make these interventions, the less effective they are, particularly over the longer term. And also it is focused only on treatment. And in our workshops in Uganda, there's a really strong emphasis on the need to raise awareness, tackle stigma around harmful alcohol use at the community level. A number of strengths related to change, potentially, if it is effective, are that it is community delivered by lay workers, which supports scalability and its relevance in those communities. It's trans-diagnostic and aligns with WHO's PM+, and so supports scalability in other settings globally. And again, there's quite a lot of potential for adaptation and expansion in other areas. So this came up a lot with the stakeholders in Uganda. Potentially adaptation for women, because there was some expressed or request for it to be adapted to support women's needs. Host populations, integration with other sectors such as livelihoods or protection, and potentially also its use in higher income settings. We've seen PM+, which was intended for low income settings, being implemented and evaluated in a high income setting and be shown to be effective, for example, with Syrian refugees in the Netherlands. And finally, and this is speculation, whether it may be something that could be adapted for other substance use. To conclude, there are clearly many challenges related to trying to implement and evaluate services for harmful alcohol use in conflict affected settings and forcibly displaced settings, which include limited international engagement and a funding situation which has suddenly got even worse. It was always bad, and now it's even worse after the Trump defunding of US aid. We have limited national capacity and very stretched health systems in order to be able to provide still more services. We have weak national policies and limited enforcement on those policies. And fundamentally, we have a rather weak evidence base on patterns of alcohol use and interventions. But there are inevitably also opportunities. So there's some progress with substance use guidelines that UNODC and WHO have been involved with, which Nadine knows much more about than I do. There's this opportunity, I think, for trans-diagnostic services that are integrated into local services and sectors. And I think that all of these provide a way of responding to an expressed demand at the community level to address this topic of harmful alcohol use. It may not be yet adequately recognised amongst, for example, humanitarian agencies or the governmental level, but in our experience, there has been demand at the community level for this. So I shall finish there, and thank you very much for your time and attention. Thank you.
Thank you, Bayard, so much for such a fascinating presentation and incredible work being done in both Uganda and Ukraine. I'll just remind the audience to please ask any questions that you might have using the Q&A function in Zoom. But I might start this section by asking you, Nadine, please, to provide a bit of a reflection on Bayard's presentation.
Thanks, Olivia. Yep, so please pop your questions in or ask them aloud if you dare. Fantastic. So before we get to the questions, but keep them coming, just want to thank you, Bayard, for giving that presentation. I think you set out really clearly how compelling the need is for us to know more about how to respond in these settings of displacement. The numbers are increasing, the situations are, as you said, chronic, and we've been paying very little attention to how to best assist communities to reduce the impact of alcohol use disorders and hazardous alcohol use in those settings. I will ask you in a minute to talk a bit more about I know you've done some work on so-called alcohologenic environments. So you mentioned the alcohologenic humanitarian response, but also some of the alcohologenic environments of displacement that that you've been working in Kiev and in Uganda, but also some of the other settings of displacement that occur in settings where people are already using alcohol. Obviously, availability has a lot to do with whether people are ending up using alcohol in harmful ways. And there are some settings where alcohol is far less available and far less used, but there might be other substance use disorders in those settings as well. So we can take the learnings from alcohol use disorders into those other settings. But certainly in those settings that you've been working in, looking at what some of the environmental factors are that might promote the alcohol use that you've been outlining. So you're particularly compelling looking at repeated trauma experiences and particularly early childhood trauma, grief, and responding to loss and some of the psychosocial impacts of displacement, but also some might maybe look at some of the bigger picture issues around availability and economic livelihoods, and whether I'm interested also in your comments on whether this is commercial alcohol, whether it's homebrew that's happening in those settings, whether that makes a difference in our response. But just I do find it really exciting that you've been really trying to address this important gap and raise its profile, and taking an approach that I think is quite interesting in terms of using lay workers. And again, I might like you to comment a bit more on that, about whether they're paid or not and whether they're volunteer laid workers. I think you mentioned the gender aspects. Who are the lay workers in this setting? The recipients of that labour were men. Who's actually being the lay worker doing that work for it. But it is exciting having that transdiagnostic approach, and that potentially as a transdiagnostic approach that might also go some way to undermining some of the prevalent attitudes of stigma towards people who with alcohol use disorders. But maybe there's also then an inadvertent capacity to promote stigma. I don't know how you measure that in your study. It certainly wouldn't be a primary one. The other thing that I thought was really interesting that maybe you can comment on is you're following people up at 3 months and then at 12 months. And we struggle in high income settings with retention in studies, and just wondered if you had a comment on how you're going to, I mean, if people are captive in a protracted refugee situation, maybe you're finding it easier to follow people up for over 3 and 12 months. But I do think that's very exciting that you do have those timeframes to see the durability of the impact. And having such a transdiagnostic, relatively simple intervention is obviously speaks to your emphasis on scalability, which is super important for us who are working in the sector, trying to develop some of those interventions. I am also interested that you're approaching probably the lower end. You mentioned that this isn't dealing with people with really severe alcohol use disorder, and what you think that means for people with severe alcohol use disorder in a setting where there mightn't be access to medical care or other psychosocial supports for families affected by someone with a severe alcohol use disorder, and what that actually means for the intervention if people are scoring, I guess, about 8 to 16 on the audit rather than 16 plus. But yeah, really exciting for me to hear about that study and to hear that you've managed to keep it going even as conflicts actually scale up rather than scale down in the situation of Kiev and Ukraine. And presumably we might be seeing more action in Uganda coming up too. So thank you. Yep, lots of questions there and lots of commentary from me. Thank you.
Thanks, Nadine. Shall I go ahead and answer those questions now before the others come through? Thank you very much. So for the question on alcohol supplies is interesting. It's one that we didn't really look at, frankly, in our study. We didn't sort of try and quantify the supply of alcohol in these settings, but I think it's a really important issue. So most of it is I'm trying to think of the correct term, but it's not industrially produced alcohol. So it's locally produced. Most of it that's home produced and a lot of it coming from the host community that live around these camp settlements where the refugees are living, and rather than necessarily in kind of factory produced alcohol. And so it does have implications in terms of if there are attempts at treatment, but also control over, it's going to have an impact at the household level of those producers. And many of those producers are women as well. And so there's a sort of gendered nature to this, and attempts at alcohol control will impact on them. So that would definitely need, if there were control measures, work on that to understand the impacts and unintended consequences, perhaps, of that. And in Ukraine, it will clearly be very different, where it's largely in sort of commercial, industrial produced alcohol. Your question on lay workers, so they were paid for the trial. So these were people from the area. They were paid in effect as facilitators, as they were called, to deliver the change intervention, but also as sort of researchers, if you like. So they were paid as part of the change study and trial. The intention is that if this were to be effective and scaled up, that it would be something that could, for example, be delivered by community health workers. Whether they are paid or not would need to be, for delivering that, would need to align with national policies on community related to community health workers. So in the case of Uganda, I think they've recently introduced a policy for giving some kind of payment to community health workers, but it's fairly low level, and they're providing a whole range of kind of health services. And the gender issue is an important one, because the vast majority of them are women. And so there's this heavily kind of potentially exploitative nature of community health workers, of women doing work that's largely unpaid. It's of fantastic importance in those community settings, that they're not being kind of compensated for. And so I think there's a broader issue there. Of course, we're happy to jump on the bandwagon, if you like, of community health workers and task shifting. But I think I come back to the point around implementation, is understanding all this from the provider perspective is really key, and we haven't done enough of that yet on these sort of briefer, scalable interventions, including the sort of gendered nature of that work. For the 12-month follow-up, it's a really good point, and it's something I could have raised in the presentation. So our 12-month follow-up response rate has been really high. I think overall it was something like a 10% dropout, and that may partly reflect that we had a great team there following up, but more likely reflect also the fact that people are largely stuck in these camps. And although there were quite a lot of the men would move out for temporary work even back in South Sudan or elsewhere in Uganda, we were able to follow them up and get them as they came back into the camp. So as you say, I think in many camp settings, whether it's refugee or IDP camp settings, it's in many ways much easier to run a trial, for example, than it would be in Sydney, quite frankly, and the follow-up rates are typically much higher. So I don't think context is a barrier to doing research in many of these settings. People often think it's not possible to do research with conflict-affected populations. It's very hard when they're in the midst of conflict, if we think obviously Gaza, DRC today, and so on. But in IDP and camp settlements, most are actually kind of fairly good places to do research. And the final point about sort of more severe alcohol use disorder, it's clearly a major challenge. All we could do is refer to the existing services that were on offer, and those were either in Arua at the hospital service there, and the inpatient mental health facility there, or if it was more severe, they then may be referred on to somewhere like Kampala. But that's the major gap. While an intervention like change may help reduce the burden on existing health services, including addressing harmful alcohol use by tackling at community level, it's not able to provide support for those with more severe disorders, and that's, I think, an ongoing challenge. And same applies to other mental disorders. In the rush for these sort of brief, scalable interventions, there's still this major challenge with people with more severe disorders not getting the help they need.
Yeah, but still the population impact should be greater. because you're reaching
Yeah,
people.
yeah, that's right.
I might go to one of the audience questions. You sort of spoke before about sort of actually having quite strong retention within this study. And I was wondering about, and Michael McGrath has also asked about this, how feasible it is to understand or assess the prevalence and extent of alcohol use disorder or other substance use disorders in these kinds of settings, so that you know what the scope of the problem is before you go in.
Yeah, so there haven't been enough studies on this, and I think Mike's question, and Mike, nice to virtually meet you again, is there definitely haven't been enough studies on this. In one of the slides, there was a systematic review, a couple of systematic reviews that have been done, and Nadine has been involved in ones previously. So there certainly haven't been enough studies on this. I don't know the proportion of studies that have been done on harmful alcohol use versus other substance use, but either way, there are definitely not enough. And I think building on what I was saying with Nadine before is in many of these contexts, it's absolutely possible to do a study on, for example, the prevalence of substance use and harmful alcohol use. Clearly, stigma is a major challenge that doesn't apply to many other health conditions, but it is possible to do these in settings. And the world is full of, for example, prevalence study, and I'm guilty of this myself, on mental health outcomes, but many other health outcomes. And I think in many cases we don't need more cross-sectional studies, frankly, or prevalence study. But in this case, we really just don't know the pattern of need for alcohol and other substance use. So I think there's a case for it. I think, yeah, Mike also asked about adaptation for towards other substance use and not just alcohol. I like to think it could absolutely be adaptable, but it would need a lot of work in order to understand, again, what the patterns of substance use were in that particular community it was intended for, and what those needs were, and how the components, the active ingredients, if you like, in change in PM+ would need to be supplemented and adapted for people with substance use needs and the level of those needs. So I think you need quite a lot of work. I've had sort of brief discussions on this point with NGOs working on this area, and they were kind of interested in it, but I'm not sure if WHO or others have been working on this. But it's definitely an area that could be explored further. Thanks for that, Mike.
Nadine, did you have anything further to add on that with your work on understanding prevalence? Or shall I go to the next audience question?
No, it's just that there are lots of, we have to tease out the contextual factors and the duration of the displacement and the different time points and what's pre-existing, even just for alcohol use, what's a pre-existing alcohol use disorder, what's a new onset alcohol use disorder, what's promoted by the alcoholic environment of long-term displacement versus short-term displacement. And what we tend to see is in the acute phase, people that were already drinking are looking for alcohol in response to the situation immediately. But then as people stay in camps for longer, that have alcohol available and that may have a sense of hopelessness and all those things that Bayard explained, then maybe that also promotes the increase of alcohol use disorder. But totally agree, each context is different. And then the big question that people ask is it different in the displaced population compared to the host population? And it's very hard to untangle those two as well.
Yeah, and I mean, just to add there, we did some work in Georgia looking at what was kind of termed the alkogenic environment and what effect that had on drinking, and this was amongst the IDPs in Georgia, and then they showed some association there. But I think all of those factors you highlight, Nadine, we really need more kind of understanding on the epidemiology and the patterns of harmful alcohol use, particularly over time, would be really helpful. Yeah.
I might ask one of the audience questions now. With the change study, was part of the eligibility criteria for participation readiness for change? And if not, do consumers who might not be able to prioritize reducing their alcohol use at the time get more support, or can they participate later?
Yeah, so thanks for that. So in terms of, those enrolled in the study, I guess had expressed a readiness for change by enrolling in the study. those so we're not able to provide services beyond those enrolled in the study. So if someone came later on and we'd already enrolled sufficient people for the study, they were not able to then receive that service yet.
And do you think there are any issues in this with sort of self-identification of needing help or recognizing one's own harmful alcohol use? Or
yeah, I mean, I think in terms of I guess it brings up the sort of validity, reliability of these sort of inclusion criteria of particularly audit, and so there's been a fair bit of work looking at the validity and a lot of work looking at validity and reliability of audit in a range of settings, including this setting. So that gives confidence that there's relevance there, if you like. But it's definitely a challenge as to the validity and reliability of that as an inclusion criteria. Yeah, good point.
Lucy has asked a question. She says that during the barriers section, you mentioned that there was a lack of support or supervision for people who administered the intervention. I think, Dean, you also sort of touched on this a bit earlier. Do you have any thoughts or improvements that could have minimized that barrier? She says she can see how minimizing this may help other populations feel like they're not being used for research purposes and improve sustainability.
Yeah, and I mean, I should clarify that. That was sorry if that wasn't clear. That was a sort of general speculation that I think with these scalable interventions like PM+, for mental health, there hasn't been enough research to understand what those needs are and support needs for those delivering interventions like this. In the case of change, it didn't come up as a critical issue, but that's partly because we had fairly intensive ongoing supervision and support. And there is a question whether that's replicable in the real world beyond the trial. But I think what came up in the scaling up workshops on how to support people delivering this was ongoing training and supervision, but also accreditation and formal accreditation. So people are being have formal certification of their expertise in delivering this. So I think that brought up a number of ways in which they could be better supported. Other ways in terms of financial support, I think very much depends on what the national policy is for example, community health workers, if they're the people that are going to deliver this in the long term.
There's lots of compliments about the project in the question section. Clarissa says, really great to see a psychological component in treatment interventions. Without it, it's like giving someone a painkiller for a fracture and leaving it at that, which is a nice analogy. Michael Farrell has asked whether kratom was a big problem among Syrian refugees. Nadine, would that be a question for you?
Please.
I'm passing on this. I haven't worked with the Syrian refugees.
That's okay. We'll figure that one out later. Renee has asked or noted whether tobacco use disorder could be adapted. Access is variable and can be prohibitively expensive in wartime, and that taboos on tobacco are less likely as religious prohibition don't play a role like it does with alcohol. Do you know of any use of sort of interventions like this to address tobacco use disorders?
No, is the short answer. There's again limited studies that have been done on this as a topic, and yeah, I don't. And I think if there has been any kind of work, it will be much more in the kind of NCD field and work around that. But I suspect not very much, if any. I'm very open to other people's opinions on that.
I think it's a great question from Renee, and it's something that I've struggled with on and off, actually even getting off the ground, even getting much community interest in doing an intervention. It usually comes from like the tuberculosis or the respiratory treatment sector that's trying to do something, but getting support for that hasn't, like I can't even think of a good example. where people have tried to do it.
And we might finish up on one of the questions from an anonymous attendee, and I think maybe you can both answer this one, is whether in your personal professional experience, are there success stories in addressing alcohol misuse among refugees or displaced populations that you can talk about?
From my side, I'm not aware.
It's a
of
big
them,
question.
Yeah, but I think we're, it's a nice question because I think we're always focusing on the negatives in academia, and there'd be a lot to learn from, I think examples of success and case studies that may often be more at a policy level than necessarily an intervention evaluation level. But with my miserable academic hat on, I suspect there aren't that many success stories on this, but it's a kind of good thing to be asking generally, I think.
I think this is why it is so exciting that Bayard's doing this work, because there are a lot of different interventions that are being done with no evidence, and I can think of people being locked and tied to trees, and I can think of frisbee competitions, and I can think of I've seen small residential rehabilitation huts, if you like, and so it's really important that we actually have the evidence for some of these interventions that are being implemented, which is why it's so great that Bayard's doing this.
Agree, and that I think is a good note to end on. So thanks, Bayard and Nadine, for such insightful discussion around what's a very important topic. And also thanks to the audience for your engagement in today's webinar and for all your questions. But before we end today's webinar, I'd like to let you know about the next webinar in the NDARC series, which will be in 2 weeks' time on the 27th of February. Valentina Lorenzetti will be talking about standard units for cannabis and the neurobiology of cannabis use and disorders. And please feel free to use the QR code and help us improve the NDARC newsletter by completing the survey below. But thanks all for joining us today, and hope you have a good rest of your afternoons.
Thank you, everyone. Thank you. Thanks, Olivia.